Bore da, croeso. Welcome to today's meeting of Powys Teaching Health Board, which is being held virtually and is live streamed via the Health Board's website. The recording will also be available to view online after the event. I'm Vivian Harpwood, Chair of Powys Teaching Health Board, and you will see on screen details of the independent members of the board, the executive members, and any additional attendees who are present and very welcome in today's meeting. Also provided on screen, you will see apologies received for the meeting today. Just to mention, unfortunately, Julie Rolls has offered her apologies and Mark McIntyre will cover for her, and we do have cover for everyone who is unable to attend. So Andrea Blaney's here in place of Katie and Dave Collington. So welcome, Andrea. Hayley Thomas, unfortunately, is unable to attend, as you see there. So if you would note perhaps that participants may look away from the screen when presenting to enable them to access documents. So moving to the agenda, which is published on our website, along with the papers for this meeting, I'll turn to the next item on the agenda, which is declarations of interest. Are there any declarations of interest, please, which have not previously been recorded? No? That's good then. So turning to agenda item 1.3, minutes of the previous meeting on the 25th of May 2022, followed by the minutes of the 8th of June 2022, which are actually for approval today. Did anybody note, apart from typographical errors, which we always go back and check, were there any matters of correction? Okay, thank you. So we can record that those are the correct record of that meeting. The 8th of June, I see that we have minutes here which would appear to be 14th of June.
That's correct, Chair. It is the 14th.
Yes, thank you. I thought it was. I was wondering where the 8th had appeared from. Right. Okay, so going through those, the same applies. Are there any matters for correction, apart from the typos, which we'll check? No, so those again are an accurate record of that meeting. Thank you. And then sorry, instructions aren't exactly what I thought they were going to be. Right, action log, please.
Thank you, Chair. Yeah, just one item on this in respect of risk management. Having this be closed by the next meeting. There's an update there for the board, as previously explained to the board, and you'll be aware of the activity that we're undertaking with regard to updates to our corporate risk register, which will be reflected in the updated risk register coming to the September board meeting, and also development of our committee arrangements, which will flow from that.
Yeah, thank you very much. Are there any questions about that? I don't think so. I think it's quite straightforward. So thank you very much. Moving on then to the next item, which is the patient experience story. So I think Claire Madsden is here to introduce this story. There will be a short video clip. So Claire, over to you.
Thank you, Viv. Today I'm really delighted to bring you Jamie's story. Jamie's a young man who lives in Powys, and this is his story about how he's coped during the COVID pandemic and his experience of having a vaccine. The video has been made with the support of his family and his care team, and we're really grateful to them, so thank you. I need to make you aware that we're also joined by a murder. I think that's a collective noun of crows. So you will hear quite a lot of birds in the background of this video, and I'm afraid we weren't able to edit them out. We are about to go into our next round of vaccine boosters in the autumn, and this video shows how important it is that everyone receives their vaccines and how the Health Board is working to ensure that everyone has the vaccines that they need. So I think, Liz, if we can play the video now, that would be great. Thank you.
Hear anything?
No, we don't have sound.
Right. I don't know if there's anything we can do about that just now. I don't know. Would you be able to summarize this, Claire, for us?
Yeah, I'm happy to summarise it. I don't know if we can try starting the video again.
Yes, let's try that. And if that doesn't work, yeah.
We did test it yesterday and it was working.
Yeah. Oh, that's the way of technology, isn't it? Always.
Another go, and if not, I'll summarise the video for you. No, it looks like it's not working. So this is a young gentleman who lives in one of our care homes called Jamie, and he found it very difficult during the beginning of the pandemic, because obviously lockdown was difficult for him to understand what that meant, and he wasn't able to do the things he normally is able to do. And the video talks about how we were able to support him have his vaccination in the place where he lives, and how the team worked to really help him understand and not be afraid of the vaccine, and the support he was given. And then the rest of the video talks about an interview with different members of the team, just explaining how it was really helpful to them that the nurses were able to go to the place where Jamie lives, and how it was much less alarming for the residents to have their vaccine in a place where they felt safe and surrounded by the people that made them feel safe. So that in a nutshell, and this is Jamie's story as he told it, with his easy read version of what was happening. So in a nutshell, that's what we were able to video, and it's a real shame that you can't hear this in the words of Jamie's family and friends.
Oh, thank you, Claire. We could see what was going on there. Oh, that's lovely.
This is just Jamie having his vaccine.
Yes, perfectly relaxed, having his vaccine.
In his favourite place with his favourite teddy bear, yeah.
Yeah. Oh, that's really nice. And oh, sweet or no? I don't know. Well, anyway, I think we can see what's going on, and I'm delighted that the Health Board is taking such steps to ensure that people who lack capacity to give consent for themselves are being treated with such respect. Oh, here we go.
And he didn't even wince. He was incredibly brave. And the first thing he asked for was, could he go and have a cup of tea? And this is
that's lovely. There is quite a lot of litigation currently going through the courts where people lack capacity, and unfortunately, and the case ends up in court for the court of protection to make a decision. I'm so pleased that that doesn't have to happen in Powys. It tends to happen where relatives object, or where the individual who lacks capacity really appears not to want the vaccination. So That's excellent. Where was that filmed, Claire? Exactly,
So,
in the care home itself?
Yeah, so Obesity Education and Care Limited home. So we went, our nursing team went out to the home and they vaccinated all the residents in that home actually with their staff and family around them as the residents chose.
That's lovely.
And this is the manager of the care home actually just saying how helpful that was and how it really helped with their logistics as well, that they didn't have to take people to different vaccination centres.
Oh, that's really good. Well, thank you for sharing that with us.
Yes, we'll sort the problem out for next time.
Yes. Well, perhaps if it could go online with the sound on as well, that would be really helpful, because I'll certainly be going back to watch it. Are there any comments about this or questions anyone would like to ask?
Chair, I think Carol wants to come in.
Yeah, thanks very much, Chair. I was just going to say that, well, first of all, a fantastic team of staff who have come together to try and support people from all backgrounds to be able to access the vaccination programme, and it was great to see Jamie's experience then. But I was also just going to say that we can have a little look to see if we can just fix that technology either for the middle of the meeting or towards the end, in order to give that its full glory. And so lovely for people to have given us the time to share their experience with us. So I wanted to reiterate Claire's thanks to everyone who took part in that, and we will fix that technological issue so that we can see it in its full glory. Thanks, Chair.
And just, Chair, I think we can load it up as a YouTube clip onto the board page after the meeting. So if anyone does want to go and look to watch it, we will make sure it's available.
Oh, thank you very much. Thank you. Did anybody else want to come in on that? I know it's a bit difficult without hearing it, but just visually, you could see that, you know, it was very relaxed. It was a relaxed atmosphere there. Well, shall we move on then to the next item on the agenda, which is the report from the Chair, Vice Chair and Chief Executive. And just turning to my own report first, I'm absolutely delighted to welcome Mererid, known to everyone as Mes Bowley, to her first meeting of our board since she joined us on the 27th of June. And she joined us just on a 12-month secondment from Aneurin Bevan University Health Board, where she was Deputy Director of Public Health, but has also been Acting Director of Public Health. So you're very welcome indeed, Mes. And the next point you see there is that recruitment is underway to appoint my successor. We're all interested in who that will be. But we have to go through the process, of course. I will be continuing to meet the independent members, probably next time as a group, and I hope that will be happening fairly soon. On the 19th of July, this is a very nice thing to report, the Chief Executive and I attended a COVID parade in the main arena at the Royal Welsh Show. A very hot day, but it was a lovely event. We had the RAF band who have been deployed around the county, or were part of the military who were deployed around the county during the pandemic, playing at the show, and they were absolutely fantastic. They played a bit of jazz at one point, which I thought was great. We were very proud to attend and receive the salute. I was happy, very happy indeed, to receive the salute on behalf of the Health Board, along with Steve Hewson, Chief Executive of the Royal Agricultural Society, and Dame Kate Bingham, who chaired the UK government's vaccine task force, steering procurement of vaccines, and also, excuse me, dealing with the strategy for the deployment during the pandemic. But this event was really our way of saying thank you to everyone involved in organising the Royal Welsh Show for the help they gave us during the vaccination programme when everything was difficult across the whole of Wales, by allowing us to use some of their buildings. So we're extremely grateful for that and absolutely delighted to be there. It was a fantastic time. Went on, I could have stayed all evening, but unfortunately we had to get home. But it happened rather late in the day, but it was very, very good. And thank you to all involved in organising it. Adrian Osborne, I know, was part of that. So that's my best news, and I like good news. So I turn now to the chair's action, which perhaps James, you'd take up on my behalf to explain what exactly happened. The board is being asked to ratify a decision taken on the 28th of June.
Thank you, Chair. Hopefully the paper and the minutes are self-explanatory with regard to the subject matter. The decision was made to support the proceeding to tribunal, and that has now concluded subsequent to that action. So that is completed. So the chair's action was to support that going forward to the tribunal. So it's for the board to really ratify that decision. And I see Carol wants to come in.
Yes, if I may, Chair, I just wanted to update that the tribunal was held as planned, and there were no points that the Health Board were found to have breached across all of those allegations. So all of those were cleared by the Employment Tribunal.
Thank you, Carol. And it clearly was the right decision that was made at that meeting by the small team who was there for the chair's action. So would you all be prepared, please, to ratify that? Thank you very much. Hands up if you like, or a little, yeah, wave. Thank you. So that has been ratified. Thank you. And now over to our Vice Chair, Kirsty Williams, to present her report.
Good morning, Bore da pawb. The report is self-explanatory. I think the launch of the Powers Forum for Suicide and Self-Harm Prevention was a highly successful event, and I just want to put on record thanks to Health Board staff that had coordinated and organised that, being able to gather partners from across Powys to support that agenda. Most importantly, the team now have been able to gather the information together from that event, and next steps have been communicated to all participants in the event. So there's a clear way forward as to what action will be taken forward as a result. The Together for Children and Young People event marks the end of that particular programme, a programme, of course, that has been led by our own Chief Executive. Again, it was a highly successful, well attended, an opportunity to celebrate what has been achieved so far, but crucially to be able to outline how the impact of that programme can be taken forward in a slightly different way. But happy to answer any questions if people have them.
Right, thank you, Kirsty. I can't see any questions, but thank you for your report. And now to the Chief Executive's report. So over to you, Carol.
Diolch, Chair. Bore da pawb. My report has been pre-circulated, so not to go through the detail of it, but we were really pleased to receive correspondence from the Minister and the Director General of the NHS in Wales relating to our integrated medium-term plan. The plan has been approved by ministers, which is excellent news. A smaller number of health boards were able to gain approval this year. That demonstrates the challenge that organisations across the NHS are facing in terms of coming through the pandemic and all of those direct impacts that have happened as a result of the last few years' events. So I have outlined for board members and more so also for the public the accountability conditions that exist in relation to our approval, and we will be tracking through and reporting against those conditions as we progress through this year. We do have an item a little bit later on our board agenda that is the Q1 progress report. That was developed just before we had the IMTP approval letter, so these conditions and the report against them is not included at this time. I'm always really pleased to highlight and note the work of colleagues across the organisation, and we had yet another fantastic certificate of appreciation and long service awards event on the 30th of June. We are holding them virtually using Microsoft Teams and things, so people are able to come to that from right the way across the organisation, and it's a fantastic part of our regular part of our calendar now. And then the one other thing I did want to draw attention to is we had a really lovely couple of hours celebrating really the Queen's Platinum Jubilee, and our catering teams from across Powys demonstrating their skills and expertise in replicating the Queen's Jubilee pudding. And I particularly want to thank those colleagues who honestly, it was absolutely phenomenal, the skill and the care that was demonstrated in drawing up those puddings. We also had a lot of fun, and whilst of course we had winners of from the panel, I wanted to particularly mention those catering teams who had to travel several hours with their puddings to get them there. But the reason I wanted to draw attention to that is that it was the first healthcare facilities and estates day, and it is really to recognise the efforts of people who work in those functions and keep the organisation running on a day-to-day basis. On a slightly more concerning note, I have pulled out for everyone's attention the issues of system pressures, and as many people will be aware, we are in another wave of the COVID pandemic, and the Office for National Statistics data just a week or so ago was talking about 1 in 17 people having a COVID infection at one time, which is significant. We have had to put in place measures so people are wearing masks in clinical areas, and additional precautions are being taken in line with our infection prevention and control processes. So people will see that as a very visible sign that COVID has not gone away, and we are having to be very careful in how we try to prevent the spread of that in our health and care settings. Positively, we are, and Jamie's story earlier points to this now, in the very active preparation stage for the autumn and winter COVID and flu vaccination campaign. It's going to be critically important that people can access those vaccinations as soon as possible, and we'll be starting that in September. And then, Chair, you've welcomed Mez, which is part of my report as well. And just to flag, another few senior colleagues have joined us from other organisations, and delighted to welcome David Farnsworth and Lindsay Schoen into the team, and to flag a couple of changes in relation to senior colleagues and their roles. So thank you, Chair.
Thank you, Carol. I can see Robert has a question for you.
Thank you, Chair, and good news on the IMTP. I have two questions about the accountability conditions. The first is, to what extent is accountability condition 1, primary care, and condition 2, financial control, mutually exclusive? And the second question, condition 4, this is about transfer from Neville Hall to Prince Charles. I'd be interested to know what we mean by optimum care. For example, it does appear that in general, Anara and Bevan treat people faster than some of the other health boards. And so there may be members of the public who are concerned that, you know, the service in the long term won't be as good. So thank you very much.
Yeah, thank you very much, Robert, for those questions, are really good ones. So on dental and money and the relationship between those, it is very clear that dental services are under pressure. I'll have the opportunity this afternoon in our annual general meeting to share a little bit of the work that we've been doing, but at a national level, we know that there is contract reform underway. And in fact, I think it was picked up in the media yesterday about the levels of, what was reported was about levels of checkups, but actually dental practice moving much more towards preventative and targeted, rather than as a matter of routine every 6 months, you know. But there are certainly people who are struggling to access dentistry. Now, we have implemented 55 new urgent appointments per week, so we've put in additional resources. We know that the contract reform will enable 7,000 additional appointments to be provided in Powys, and we've set up a dental access support line, of which over 5,000 people in Powys have already accessed that, and we've helped those people to find dental appointments. So we have been putting some additional resources into that, Robert. Some of the root issues, however, relate to the training of dentists, the workforce challenges that there are, and I'm really pleased that work in the dental part of our primary care function is looking at the development of roles such as dental therapists to be able to support the overall package of care. It is right, though, to make the connection between service and finance. We will cover a bit later on in the meeting how difficult the financial position is at the moment. It is extremely challenging. We've got a lot of demand on the NHS, and we have got a finite amount of money. But we are an organisation that has, you know, £350 million at our disposal, so we have to be able to manoeuvre that resource to the priorities that we set as a board and government expectations. Then on commissioning one, it was quite interesting for me to see that, and you're absolutely right, that phrase about optimum care, because, you know, my view here is I can't imagine any, not very many people across the NHS at the moment, with all of the system pressures that there are, describing a high rate of optimum care for patients. So we know patients are waiting too long for their planned care procedures. We know they're waiting too long in their urgent and emergency care pathways as well. So that is quite a challenge to be able to guarantee optimum care when we're under that sort of pressure. Nonetheless, we have got mechanisms in place to be reviewing the quality of care and the outcomes that people are experiencing. And to date, and of course, the move of the pathways to Prince Charles took place in November 2020, so it's had time to bed in. We are not seeing any increase in complaints. In fact, I can say to you confidently that I have not seen any complaints about the care in Prince Charles coming across my desk, certainly over the last year or so. That's not to say that there are things that could be improved, and we'd always welcome that feedback. But Robert, we will be looking very carefully, not just at the Neville Hall Prince Charles move, but across all of our providers for that quality of care. And we'll be demonstrating that. We are reviewing at the moment the commissioning assurance framework, for example, and we'll be illuminating that publicly about the quality of care that's being experienced.
Yes, thank you, Robert, to Robert Lewis there for those questions. Do you want any follow-ups, Robert?
No, thank you. Thank you, Carol.
Yeah, good questions. And Ronnie Alexander has a question as well, Carol.
Thank you. Good morning, Carol. I have 3 very quick questions on system pressures. The first one of which is, I wondered if the change in status that WHO has awarded to monkeypox status does produce any operational issues in relation to the health board in the short term. And the second question, again reflecting on system pressures, given the reorganisation of NHSE, HE and NHSD, which will reduce staffing complements in England by between 30 and 40%. I wondered about the implications of that for the work of Powis Health Board, particularly in relation to commissioning and the work of the ICS teams. And on the third point, it's been a little while since we've heard anything about displaced Ukrainian citizens. I was interested to see yesterday that there is now a cruise ship in Edinburgh to give those in Scotland temporary housing accommodation. Now, I know temporary housing accommodation in Wales is not the responsibility of the health boards, and I'm not suggesting that, but I just wanted to be reassured that you were fully across the needs that displaced Ukrainian citizens have. Thank you.
Thanks very much, Ronnie. Really interesting questions. So, and I invite Mez to make a comment if there's anything to add above what I'm going to say. So on monkeypox, it hasn't had a significant impact on us here in Powis. That's not to say that work hasn't been done, because it has actually. The public health team in particular have been working diligently around our responses to this emergent issue, as you quite rightly said, has been escalated in the WHO rankings, if you like, of issues of concern. We do work with other organisations, particularly around sexual health services. So that is a partnership approach rather than a more unilateral sort of health board approach. In terms of changes to NHS England and NHS Digital, we haven't seen the impacts of those changes coming through, but what we have been able to do is connect with colleagues in the integrated care system at this stage in the Shropshire, Telford and Wrekin area, and we held an executive to executive meeting with the system leaders about 10 days or so ago. Very productive indeed, and our agendas, even though we're in different parts of UK nations, our agendas as an NHS are very, very similar. So we're tackling the same issues. We largely have the same approaches and thinking on that, and that bodes really well for our continued relationship with the Shropshire, Telford and Wrekin area. We hope to do the same with the Hereford and Worcestershire ICS after the summer break and have an exec to exec with them. On displaced Ukrainian citizens, in my last report, I'd updated the board on that. I can say that further intensive work is underway and has been continuing. I'm delighted that Mez has joined us and sort of hit the ground running in relation to this. And we're trying to ensure that we can be a welcoming county, working closely with the local authority, but also to ensure that we get the numbers right, the placements right, because there is a need to support people with access to health screening and other health support, and that needs to be carefully calibrated, really, to ensure that we are able to adequately respond. Ronnie, you allude to the developments in Scotland. I think there is pressure on accommodation in Wales, and that's one of the things that we're very, very mindful of in our working with the local authority here. We are having to put some additional resources in, and we will be having a conversation with government about how they can support us in that regard. But Chair, if that's all right, I'll just check whether Mez wanted to add anything.
Hi, yeah, I think you've covered it all. Just on monkeypox, just to provide assurance, there is a national IMT led by Public Health Wales, where all health boards participate, and there's very much close working across all the health boards with pathways in place. So, and no current impact on our sort of services, but obviously we are prepared and providing the pathways that are required.
Thank you, Mez. Thank you.
Thank you.
Ian Phillips, also an independent member, has a question.
Thanks, Viv. Carol, I just wanted to come in on the back and build on the stuff on the Ukrainian refugees. This is a bit, I don't want this to sound mercenary, but I just wondered whether we are exploring the opportunities for employment of refugees who may be healthcare professionals, and whether there's work to do that. That seems like a win-win.
Yeah, thanks very much, Ian. Absolutely, we have been having some discussions about that on a wider basis from an NHS Wales perspective, and actually, you know, even into social care. So they're not in Powys, but I happen to know that there's been a dentist come across. We were just talking about dental issues earlier, and so I'm sure that health board area will be supporting people who have those, you know, unique skills that are, you know, going to make a big difference to their new local communities. I haven't got a breakdown of the skills that people bring across, Ian, but I'm very much with you in terms of trying to utilise those skills, those qualities in the local area if we can. One of the challenges we've got at the moment, Ian, is that we don't know how long Ukrainian citizens will be staying in one place, and that links to the accommodation issue. And I think once that settles down, that will be an easier road to walk in terms of providing employment opportunity, but absolutely been picked up at a Wales level as well, Ian. Thank you.
Thank you.
Right, thank you for that question, Ian. I think we can then turn to the next agenda item, which is the items for section 2 of the agenda, items for approval or ratification, and to the Welsh Language Standards Annual Monitoring Report, very colourful report, which I enjoyed reading. And I think Claire Madsden is going to take that item.
Thank you, Chair. Yes, this is as part of the statutory duty under the Welsh Language Standards. The Health Board is required to produce an annual report for each financial year and outline the steps it's taken to comply with the Welsh Language Standards. I would like to just note with this report was during the time of the pandemic, and we did actually redeploy this team, both the Welsh language and the equality team, with regards to the next paper as well. And so we did stand down some of the work, and it's just worth noting that this team did actually make a significant contribution during the pandemic as we redeployed them to help roll out the Attend Anywhere virtual system for patients. So they were actually doing their job by supporting patients to access clinical services during a time when it was difficult to access services. So we did use them to their widest range of abilities during that time. So the report is a descriptive report, and it complies with the requirements of the Welsh commissioning standards. So I'm happy to take any questions on the report.
Thank you, Claire. I don't know. Oh, yes, I think Ian, a very keen Welsh learner who's now very competent, I have to say, has a question. Ian Phillips again.
I suppose I should start that with Diolch yn fawr, Viv, in the light of that comment. I just wanted to two things really, and that's to put on record our thanks to the staff to have made progress despite the fact that they were being asked to do other things. So that clearly it's great to see the progress. I did spot a couple of minor typos, Claire, which I can tell you outside of the meeting on the full report, if that would be helpful. What I wanted to know in terms of the last page and moving forward, when we talk about the obstacles that prevent staff from taking up training opportunities, whether when that work is completed, that we can be informed of the outcome of that, so that we're clear about the things that we can and can't do.
Yeah, of course, we'll put that in the next report, Ian, no problem.
Thank you.
Yes, thank you, Ian. I mean, that's the section that I read with interest, that moving forward section, because I was aware of the redeployment of the staff. And it looks as though we do still have quite a lot of work to do on this. But there is a plan, which is always good.
And we're really working hard at the moment to populate the intra-network. So we've got resources available to support staff in all the different areas and levels that they need.
Thank you. Right, well, thank you very much. So we are asked to approve the report subject to the correction of a few typos that Ian is kindly going to send you details of. So is everyone happy to approve? Thank you. Right, right. The next item then is the Equalities, Diversity and Inclusion Annual Report, also a very important report. And I think also for Claire.
Thank you, Chair. So as I said, this is the same team that worked together. So again, we had limited work on this due to redeployment, but as part of the statutory duty under the Equality Act 2010, the Health Board is required to publish an annual report for each financial year, and that's outlining the steps it's taken to meet the public sector equality duty. So again, this is a descriptive report and just details the work that the equality team has managed to achieve in the last year, and again setting out the aspirations that we have for the coming year. So happy again to answer any questions.
Yes, thank you. I mean, it's all there in the report. Robert Lewis, another independent member, another question from you.
Thank you, Claire. I know you've been a champion for this before. This extension of musculoskeletal practitioner services. The data are quite startling, aren't they? There's no reason to suppose the data for England doesn't apply to Wales. 17 to 30% of GP appointments are in this category. So two questions come from that for me. The first is, where are we going to monitor the benefits of this program? You know, which committee is going to examine it? Because potentially this will make a big difference to GP services, I presume. And the second thing is, will this program be diagnostic neutral, or will it end up requiring more diagnostic services to cope with the alternative pathway? And just to add that I'm interested for lots of reasons, but one of them is, of course, that there is a geographic inequality as well with access to services. So things like this tick the box in all sorts of ways. Thank you.
Yeah, thank you for that question. So we've got a large piece of work around musculoskeletal as part of our renewal programme, and we've had the GERS report, and that's looking at all the opportunities and options that we have to you know, make sure people have the right treatment in the right place at the right time, and that includes working with GP practices to see patients straight away and make sure they've got the right advice and guidance, and also to make sure then people are signposted to the right places and they're as well prepared as possible if they do need surgery in the future. So the renewal programme will monitor the improvements in that area, and within the musculoskeletal team at the moment we do have a big PROMS and PREMS, which is patient reported outcome measures and patient reported experience measures project going to really look at making sure that we are collecting data around both of those areas to ensure that our service is effective as well. And in answer to the last part of your question around diagnostics, I think we're probably in the early stages of that, but we're certainly looking at which diagnostics we can repatriate back with regard to musculoskeletal back into POWERS. So one of the first areas we're certainly looking at is musculoskeletal ultrasound, and we do have a podiatrist now just qualified to do some of our musculoskeletal ultrasound, and we are looking at training other staff so that we will be able to improve our diagnostics within POWERS. And then again, as you say, we need to look at what diagnostic needs we will have in the future to ensure we're offering patients the best service.
Okay, thank you. Happy with that response?
Yes, thank you.
Thank you for raising that. I can see Kirsty Williams has a question.
Thank you, Chair. Claire, I appreciate that the report is focused around requirements under equality legislation, focused primarily on protected characteristics, but inequality can exist in beyond those protected characteristics. And I'm just wondering how the team is able to support other members of staff in the health board to check that policy development doesn't reinforce existing inequalities that exist, that we already know about, and in our attempts to move progress. And I'm thinking specifically from a geographical perspective and access into different services, we're seeing a differential rate in which some of our commission services are able to support POWERS residents, which means potentially you'll be seen much more quickly if you live in a certain part of the county and access a certain service as opposed to another part of the county. And I'm just wondering how the work of this team can support other executives in making sure that any decisions that are being taken aren't increasing inequality above and beyond that of the protected characteristics which are noted here in this document.
Do you want to come in, Carol, or I'm happy to start the answer?
Well, I was just going to, if that's okay, Chair. They were my comments, Kirsty. You know, absolutely. I wanted to add that whilst much of this is as you quite rightly say is rooted in protected characteristics, actually inequalities. It's beyond the team. It's a whole organisation commitment. There's systems and processes that we will need to keep developing, because those health inequalities, those socioeconomic inequalities, the inequalities that exist, one of my key points that I like to make regularly, the inequalities between different groups. So people who have a serious mental illness, for example, have poorer general health than the general population. So we've really got to be very clear about where those inequalities and name them, and then be very clear about the action we're actually taking. So I think, I was just going to comment that I think this is a great work, but we've got to think even bigger here, because we've got to be an organisation. I think this is in our principles in our health and care strategy that roots out those inequalities and takes positive steps to reduce them. I think that's in the core purpose of the Health Board. So I wanted to agree with those comments really, Kirsty, and thanks, Claire, sorry.
Yeah, I was also going to agree. And I think one of the things we are really trying to do, Kirsty, is really encourage equality impact assessments whenever we have a new policy or a new development within our organisation, and we have standardised that approach to make sure everyone has to do it. And the Equalities team are supporting and advising people when they are doing those assessments now to make sure that they are really, we don't want this to be a tick box exercise. We want it to be an opportunity to really look at what we're doing and make sure we're approaching it from every angle, really. So this team are really championing making equality impact assessments meaningful at the moment.
Thank you, and thank you for raising that, Kirsty, because if you hadn't, I would have. So very, very important to remember that, and it must be part of everything we do, every policy that we think about and discuss. So thank you very much, and thank you, Claire. If there are no further comments, we'll move on to the next agenda item, which is actually, oh no, we do need to approve that policy. Sorry, we do need to approve. Is everyone happy to approve the Equality, Diversity and Inclusion Annual Report for 2021 to 22 for publication on our website? Thank you. Thank you, those who've said yes. And we'll move on then to the next agenda item, which is only for discussion, actually, not for approval. And I think, Mez, you are going to introduce this, and Alison Mary will take over from you. Is that right? No, just Mez. Okay. Sorry.
Just me. Thank you. Yeah. So thank you, Chair. So the purpose of this paper is to bring to your attention and to make you aware of the work that's underway around healthy weights and prevention of obesity. So healthy weights and healthy weight was a strategy that was published by Welsh Government about 2 years ago, just on the advent of the pandemic. And the aim is to prevent and reduce obesity rates. So as part of our sort of national, but also in our local ambition, is that we want to have for our future generations, our children and young people, to give them the best start in life and to live longer and healthier lives. So being a healthy weight has become one of the most effective ways to reduce the risk of preventable long-term and chronic conditions. But preventing obesity, though, is a complex challenge, and many factors influence at individual, societal, community and environmental levels. So our lifestyle behaviours are influenced and driven by the environment around us, the culture we live in, and our ability to make changes. So the paper itself outlines how some of these complex areas interact with one another, and the complexity of the obesity system means that there is no simple solution or quick fixes to tackle obesity, and no single organisation can tackle this alone. So it's an important area to focus on and take forward, and it's important that we adopt a whole system approach to work with a wide range of partners and communities in this area, and this is about sort of leadership across the system to enable change. So pleased that you mentioned Alison, so she's leading this piece of work within the public health team, and a workshop is planned for September, so to start to map the whole system and to get common understanding of all the local systems, identify areas to influence effectively, and then to create change with a view to improve outcomes. So there's further detail in the paper, and I'm happy to take any questions. Thank you.
I don't know if there are any questions. Claire, did you want to comment on this, or no, that's an earlier message, I think. Yeah?
No, yes, please.
You did?
Yeah.
Okay, Yeah.
Thank you. Good morning, everybody. Apologies that you can't see me. Unfortunately, my laptop camera is not working. Thank you, Mez, for the paper. And I was at the Start Well board yesterday, where Alison presented a presentation to the Start Well board. And interestingly, you know, you're absolutely right about no single organisation can solve this issue. It is a whole system approach. There was a very good discussion in the Start Well board and the commitment to be able to take this area for discussion at the Start Well development session in the autumn. So I'm very happy to pick that up with you outside of the meeting, but wanted to share that there was recognition that there is a whole system approach required. Thank you.
Thank you. Any further discussion, Carol? Sorry, I didn't see your hand.
Not at all, not at all. I think potentially this work is an absolute game changer for the health and well-being of the population in Powys. And I think Mez has alluded to the impact of weight management, of obesity on long-term conditions, on rates in terms of cancer rates, etc. But also overall emotional health and well-being as well. So, you know, if there's one thing that actually agencies and the public across Powys could get behind that leads to very tangible differences, it is this. And I was talking to someone from the sports sector a couple of days ago, and the role that sport has and leisure, you know, whether that's, you know, walking or something a bit more active like the women's football and all of this, that sort of thing that's attracting the headlines. You know, having this as a sort of collective endeavour feels really, really key. So I am hoping, Chair, I know that we've got an opportunity at the Public Service Board level to bring forward some of these big items into a workshop that is coming up soon, and I'm certainly hoping that our colleagues around that wider partnership arena would be able to support and get behind this. So I just wanted to sort of commend the work really and the ambition behind it.
Yes, thank you, Carol. And we all find enjoyable ways of doing exercise, not necessarily playing football in my case, but you know, there are certain sports. There's always something by way of exercise that anyone can do. So even people with disabilities do manage to participate, which is really important. So thank you. Ian Phillips again.
Yeah, thanks for this, Mez, and thanks for your comments, Carol. I must admit, I find this a really difficult subject in terms of, I guess, figuring out what we can do that's going to make a big impact because it is so multifactorial. And so I guess the question for me would be around needing greater understanding of this work, because it seems almost endless in terms of the factors influencing this. I'm reminded of a cartoon which shows a big queue outside a GP surgery, which states the strapline is something like if exercise were a pill, we'd have a long queue for it. So for me, and it may be my lack of understanding, this seems like a really complex piece of work, and at this moment in time I wish you all the luck in the world, because I have no insight as to how to take this forward. It seems to me that it's on a trajectory that's fairly similar to global warming, and probably of equal scale. So I look forward to finding more out when you've had your workshop and are able to hone in on a specific piece of work. Thank you.
Thank you, Ian. Kirsty again.
I just wanted to follow up where Ian ended. I mean, I think it is the problem is so vast. I think it probably does feel a bit daunting, and a question of kind of where on earth can we start. And I think that's why Claire's comments about the Startwell board is so important. And the ask of the Startwell board yesterday was that this agenda was given more prominence in the work of Startwell, which lies underneath the RPB, because I think if we can get in early in a child's life, indeed before a child is even born, actually we can then go on to make a difference. And I think the other crucial thing that we can do as a health board is provide a pathway of support for people who have been living with obesity to take action, because evidence shows to do that without support is very challenging. You have a 1 in 4,000 chance of actually doing something about it if you're trying to do it without support, if you have been living with obesity for a long time. So I think the crucial thing for us, which is I understand is taking place at the moment, is the development of a pathway through so that there is support for people to take action. But that then is the challenge again of recruiting staff and making sure that that service is equitable for everybody across the county. But I think it's really important that those of us that go to Startwell board, Claire and myself and other staff, that we raise the profile of this work and some of the projects that are going on, because I think if we can stop chucking people into the river, we won't have to fish them out later on.
Thank you, Kirsty. Some good comments there. Mark Taylor.
Thanks, Chair. Just want to support some of what Kirsty was saying in terms of, I think it's starting at an early age with expectant mothers, parents, and basically those models that people will adopt, and some of it is genetic and you're going to have difficulty changing some of that. But I think the other thing in terms of services is consistency and long term, because one of the worst things is people will yo-yo, and it's that consistency of support which I think at the end of the day will deliver the greatest benefits. Thank you.
Yes, that's a very good point, Mark. Did you want to come back on that? No?
Yeah, thank you. Just to say, absolutely agree. There are sort of actions that can be taken around environment, settings, people, and obviously leadership behind that. But fully support, really, you know, that we focus in sort of one area, and really pleased to hear that the Startwell board yesterday was endorsing that as well. And I think giving our children the best start in life is an area that we can influence and have impact as well. Thank you.
Thank you, Mez. I mean, it is very important issue, and we've had a good discussion and noted the report. Yes, thank you very much. And I think we can move on to the third section now of the agenda. And it's the integrated performance report, very important. Stephen, do you want to come in straight away with this? Stephen Powell, you're going to present, I understand.
I am, thank you, Chair, and morning all. So we're looking at the pack, and it's page 85 of the board pack as presented, and I'll take you through the structure of the report, comment on some items, and then at the end draw out some of the notable exceptions that I'd like to draw board members' attention to. So page 2 of the report gives the overall summary of the performance to the end of May, month 2 of the new financial year, and the structure is similar to the format previously presented in terms of the quadruple aims and the performance versus compliant or not compliant across those 4 aims. As we've already touched upon during the meeting, the impact of COVID is still having quite an impact, obviously, on our performance, particularly in our commissioned services, whether we're talking about planned care or emergency care. There are still significant pressures that are impacted upon those targets. As a provider arm, we continue to make good progress, particularly in planned care and recovery, but there are still some challenges which I'll discuss with colleagues during this presentation. Slide 3 goes on to describe the COVID position, but obviously given the change now in both the testing regime and the tracing regime, some of this information is now not necessarily out of date, but it's factual, but not as up to date as it used to be. And the more of the indicator of COVID in the community is now reporting more so through the ONS data in terms of incident rates, as opposed to the way that we report in before. Slide 4 is a snapshot of our COVID vaccination program, and as we've discussed earlier, this now will pick back up in the autumn as the new JVCI rules for vaccination have been published, and that program will recommence from September onwards. Page 5, I wanted to draw members' attention to the changes to national reporting and the ministerial measures and the NHS delivery framework, and the merger of the two indicators into a new long list effectively that will be reported from during Q2 onwards. So the page 5 describes the 84 ministerial priority measures. The slide also goes on to discuss 25 new measures that have been introduced. A number of measures have been retired, and the slide goes on to describe how we will be expected to report these indicators, both to ourselves, but also to the various outlets in Welsh Government and across the NHS regulatory framework. Slides 6 to 8 describe the high-level performance against the ministerial outcome framework, and these are largely access related in these particular slides, and this is a performance of our own provider arm services. And I'm pleased to say that the effort that the team has made, we're achieving the target, the recovery trajectory targets that we've set out. In many cases we're ahead of them. Probably the only notable area of concern is that whilst we're saying that we're below our agency spend as a percentage of our total pay bill, we are nevertheless continue to use quite a high level of agency expenditure, which I'm sure my colleague Pete will pick up as part of the finance presentation. Slides 9 to 14 then describe the performance of the health board in the performance scorecards, and as I say, I will come back and draw out some of the performance items at the end. Page 15 to 66 then go through the very detailed performance of each indicator, the issues, the actions and the mitigations that are occurring, particularly where some of the indicators are off target. Page 67 describes the next steps, which includes not only the implication of the new ministerial measures, but also how we need to then embed that those indicators into our internal reporting and through our onward IMTP as the year progresses. And finally, we've developed our reporting in pages 68 onwards to include much more information around long waiting patients, particularly in commission services across England and Wales. So at present, this shows the number of patients waiting over 36 weeks, but in the next report, we'll be showing patients that will be waiting more than 104 weeks, because we now have access from next week to a much greater level of detailed information available from the delivery unit. And one area that I particularly want to develop, which picks up on both Kirsty's comments, is then look at not only how long those patients are waiting, but where they actually reside, to pick up on either socio-economic impact of their wait on those waiting lists. So that should be available as an additional supplementary report in the next report to board. In terms of just going back and talking about some of the exceptions, In quadruple aim 1, there is an increase in the number of alcohol admissions to secondary care. Now, this is a complex issue, and it was picked up as a news article, which I heard last night, that they're generally, during COVID, it seems that there's been an increase in alcohol consumption, particularly at home, which could have possibly led to these then increase in admissions. It's a particular area of work that we need to do more focus upon locally to see what additional intervention, education or services that we could develop, but certainly one that was being picked up nationally yesterday. In quadruple aim 2, our dentistry figures are not where they should be in terms of access, and so there are a couple of indicators there that are not compliant. But as Carol said just now, the revision to the new dentistry contract is hoping to improve the volume of capacity available to patients, so that we can start seeing a better access for patients and then better performance and outcomes. Would you like me to pause there, Chair? I think there's a question come in, or a couple of questions.
Yes, there are some questions coming in. There's a huge amount of material here, and you know, an awful lot to plough your way through. So we'll have a look. Yeah, who was first with a question? I'm not sure if it was Kirsty. Were you the first person? No, Mark.
Thanks, Chair. Yeah, it was just a general observation in terms of a welcome as to the approach that the renewed and more full data will give us in terms of actually using performance to improve things. And I think one of the things we suffered with is specific POWERS data on occasions, and as that sort of becomes more usable and richer, I think that's going to, as Stephen alluded to, looking at the waiting times is going to be very good in terms of being able to target some interventions where we can. The other one was a general point as to vaccinations, and in particular influenza. And I was wondering, given the logistic issues we've had in previous years and still ongoing, as to whether we are any sort of intelligence as to the availability of vaccines going forward into the flu season. Thank you.
Right.
Okay, thank you, Mark. If I just pick up, Carol, did you want to come in?
Wants to come in, I think.
Oh, I was just going to offer a comment on the data, if I may, and I just thought it was an opportunity on the back of Mark's comment about data. So I have stressed to Welsh Government the need for resident population data sets and not provider data sets. So I do want to underline that some of the data in this pack has a provider lens, particularly against the ministerial measures. And I, for clarity, don't want anyone to be under the misapprehension that we don't have patients waiting considerable lengths of time for access to services, but they're not in our direct provider. They are in our commissioned services, as Steve was saying. It's just the data that has been available and comes through those more official routes through Welsh Government has been provider focused, and the Deputy Chief Executive of NHS Wales has committed to taking that back and looking to resolve that, so that the extent of the challenge, Mark, can be openly and transparently shared amongst us all, and including members of the public. So I just wanted to make that comment. I don't know if Mez wants to comment on vaccine availability, but it's been one of the key things, I think, from a Welsh Government point of view. They've wanted to ensure that we have the maximum available stocks on flu vaccine that we know we can possibly have, given some of the Southern Hemisphere patterns of influenza. So I don't know, Mez, if you wanted to come in on flu.
Yeah, thank you. And I suppose I'm glad really that this focus is raised on flu, and as Carol's mentioned, really the southern hemisphere have really seen an increase in flu activity this year. And it'd be fair to say the last 2 years, both in the UK and southern hemisphere, there was very low level flu activity, and that was probably because of our behaviours in terms of wearing masks, you know, hand sort of sanitation, etc. So and there's been a focus in Welsh Government and across health boards to have an increased focus on flu vaccination going into the autumn and procurement of that vaccine. So we're not aware of any delays as yet in flu deliveries going into the autumn. And there'll be a focus obviously both on COVID and flu vaccinations and media activity planned at a national level, and obviously plans locally as well to support that, to encourage people to come forward for their flu vaccination.
Right, sorry, is that all right, Mark? You're happy with that?
Yes, thank you.
Right, Robert Lewis next.
Thank you. A quick question on MIUs. Some months ago, it was my understanding that we were looking at whether we could do anything to enlarge our provision at MIUs. This followed our discussion, I think, last October with the Commissioner, etc. I just wondered if that work had be concluded. I mean, maybe that we can't do anything and that we have to look to make contributions to reducing the demand on ED elsewhere. I just wondered if we could have an update, please. Thank you.
Happy to come in on that, Chair, if that helps.
Yes, please,
Kate Wright is on leave at the moment, Robert, otherwise Kate would respond to this. So the latest position, the update that I've received is in relation to the urgent emergency care work and the frailty and community model work under one of our renewal programmes that Kate and Hayley Thomas are co-leading. There is some work looking at the potential for increased what's called same-day emergency care. In short, it's SDEC, and the role that an MIU alongside things like virtual ward may also play. And just yesterday we had a discussion about the potential proposal on more ambulatory care provision within Powys, and again, you know, the connection piece with MIU will be quite important in relation to that. So it is there, and I think Robert, that as part of our renewal programme area updates, we will be bringing an update back to either the board committee or the board itself. We've got obviously cancer on the agenda today, but the frailty and community urgent emergency care will come back through with a bit more detail than I'm sharing at the moment.
Thank you, Chair.
Thank you. Next, I think was
sorry, Chair, just to expand on Carol's comment, this also ties into our strategic intent that we're developing for diagnostics, because that's also key to the both identity and delivery of an expanded MIU offer locally.
Yeah. Yes.
Thank you.
Really
so
thank you.
There were one or two items I still wanted to raise, Chair. Oh, sorry.
Oh, Ian had a question as well. Ian Phillips.
Thanks, Viv. I just wanted to ask on the influenza stuff, and the Mez has already alluded to the fact that there's a concern about increased amount of respiratory infections that might be on their way. And I just wanted to just read in page 21 of that presentation there. We've previously heard about the significant success in the maternity area for doing this, whether we're learning the lessons. Now, clearly it doesn't transfer across perfectly, but rather than increasing access, a more proactive approach to delivering the vaccination has clearly worked for pregnant women, and I just wonder whether we're exploring a more proactive approach, particularly for our staff as well, actually.
That for you, Mez, again.
Yeah, happy to come in. Yeah, sort of absolutely. There are work streams underway, really. There's lots of learning from COVID vaccine and how that's been delivered as well, that we can translate into delivery of flu. And there is an ambition where possible to try and co-deliver COVID and flu. We're probably in a transition year this year, and we're looking at how we do that for staff as well.
Sorry, Viv, if I may come back. I was specifically with my understanding of the maternity, we were getting the mothers in different appointments rather than through flu appointments or through vaccination appointments, and I just wondered whether there were opportunities to get, for want of a better description, I can't think of a less pejorative word there, get our staff when they're doing other stuff, rather than expect them to come to something, because that's been the approach so far. We can increase the availability, but we haven't been that successful in increasing uptake. So that's where I was coming from.
See what you mean, yes.
I'm happy to come in, Chair, if that's okay. I think there's two things, Ian. And Mez will not yet be fully familiar with this, but in years gone by, sort of pre-pandemic, in the pre-pandemic era, Powys was the health board with the highest staff flu vaccination uptake, and we were very proud of that. We didn't have financial incentives or other incentives. It was a let's all do the right thing type of incentive and motivation. That has been really affected, I think, by the change in working patterns, more working from home. And the last couple of years, we have seen a dip in staff vaccination uptake. Hence, I think it is going to be quite an important strategy wherever we can to co-deliver flu and COVID vaccine for health and care workers. But we also have this network of peer vaccinators. They were nominated recently for a certificate of appreciation. So I think Claire Roach had the job of reading out every single person's name, and there were many of them, and fantastic contribution that they make in providing a vaccine in the workplace rather than people having to travel for that. And I think Ian will be taking another look to see, well, is there another layer beyond that we can add in for this winter? But had an opportunity last week in the staff briefing to really flag this issue as being really key. So on staff, I'm expecting us to be able to improve on the rates of last year, and ideally quite significantly.
Thank you.
Thank you. Now I think we have to press on. We are almost falling behind a bit. So Stephen, you had said you had a couple more points to make.
Yes, so I'll be brief, Chair. I just wanted to really mention the deterioration in the Red Ambulance performance for the month of May. Now, we've discussed the system pressures across the whole NHS, but that obviously is bearing through on our figures as a health board. Mental health part 1, that's indicator 44B, that is still below standard. Now, there's been quite an increase in the number of referrals into that service. It's up 25%, and in real terms, that's an additional 250 referrals. Plus, the team has had some staffing challenges, including having to support the local authority in the delivery of their duty team service. So that is behind target. There are plans to return the service to compliance, but at the moment we're a bit behind on those actions that we previously said that we would take. And finally, Chair, indicator 59, the concerns, the there was a deterioration in the response. So I'd like to bring in Claire Roach on just on that one, if you could, Claire, please.
Okay, thank you, Steve. And this was a key focus of discussion at the last Patient Experience and Quality Committee, where we looked not just at the quarterly data, but at the monthly data over the last year or so, to be able to look at the trend in our compliance. And, you know, very rightly, there was a challenge from the committee about not just improving, but having a sustainable improvement. So we committed in the next quality committee on I believe it's the 13th of September, we will be focusing on that and bringing a presentation, being able to demonstrate the actions taken to date and the proposed actions that we need to take forward. Thank you.
Right, thank you. So thank you for that, Stephen. Were there any other questions for Stephen? Huge amount of information, as I've said, and very useful to have this here so that next time we can see, you know, what improvements have been made throughout. So thank you very much. We hope all improvements from now on. Shall we turn then to the IMTP delivery?
Yes, thank you, Chair. So as colleagues look at the pack, this is page 156 of the pack. And there are two sections to this report, and this is for approval. And so there's an 11-page covering report that summarises the IMTP position for the first quarter. At the time of writing, this paper said that the IMT hadn't been approved, but it subsequently obviously has, as Carol indicated. And the way the report is structured, it focuses on the 8 high level of wellbeing objectives of the health board, supported by the 25 strategic priorities, and then each priority has got a series of actions to deliver the priority to deliver the objective. So there's almost a pyramid of actions that we've attempted to summarize into these reports. In terms of its visual presentation, we've created some pie charts to show the progress that's being made, so that features on page 2 of the report. So for the 8 strategic objectives, we've arranged the performance in that way to give the reader hopefully both a visual and a summarized position on each indicator. There are, by and large, we're making good progress in our position at the end of quarter 1 on our IMTP. There are 1 or 2 reds across goals 1, 2, 3, and 8. But despite some of the sort of staffing challenges and operational challenges, we've had a good start to the year, I would say. Quarter 2 performance is key now in terms of a key deliverable quarter to set the scene for the output for the financial year. So we'll be keeping a close eye on the performance during quarter 2 to make sure that we're on track later on in the year. This report is due for submission now during July to Welsh Government. And what we've done is support the summary level detail with a 28-page. Oh, we've paused, Chair.
No, I don't think we have paused yet, so keep going.
Okay, thank you. So the summary report is then supplemented by a 28-page, more detailed report that summarises the activity at either at director level. And in terms of, again, visual presentation, the green sections on each of the slides just gives that overview of both the performance and any issues where items may be off track, particularly the red rated actions. So this is the style of the reporting that we want to develop now across the year, because as I said, there's a huge amount of detail that supports the delivery of our IMTP. Yes. So I'll pause there, Chair.
Thank you. There is clarity in this anyway, and thank you very much. Mark Taylor has a question.
Thanks, Chair. It was just a quick question on the Wellbeing Goal 7, innovative environments. It looks a very positive outcome in terms of the pie chart. I can understand that in terms of reporting clear cut on terms of capital programme, etc. But I'm not sure that that would sit with my thinking in terms of where we are in terms of carbon reduction and commitments and ongoing work around that. I would have thought that one would still be more of a work in progress, and therefore I'd expect to see less green as to that sort of current status. That may be just my perception, but just wanted to raise that. Thank you.
No, thank you, Mark. I mean, the performance is rated against the actions we said we would take. I mean, clearly the carbon reduction is a much longer term piece of work, and I think those longer term actions or medium term actions, they need to be will feature in plans later on in the year, but certainly in next year.
Okay, thank you. Happy, Mark?
Yeah, thanks. It's just raising it as a point, and I think as we look at that, it becomes more apparent as we go along.
Yeah. Carol?
I just wondered, Chair, yes, thanks very much. Mark, Steve alluded to this, you know, the new style of reporting is under development, and there are different levels of detail, and as the chair of the Delivery and Performance Committee, I would expect you to have a level of detail which is more than we've presented at the board level, and that those challenges and discussions can take place in that committee. We've got a little bit of work to do on ensuring moderation of the ratings. So there was a little bit of discussion about one or two of these, and actually the connection between these two reports that we've got together, which is the actions, maybe green, what's the outcome looking like in terms of the deliverable impact. So we've got to make a connection between the two. So there is more detail in the reports that I have in front of me as well, and so we can make sure that the relevant committees gets the relevant detailed sort of scorecards, and that's something that Steve and I are working on together.
So, I mean, this is work in progress, as it were, not only in meeting the requirements of the IMTP delivery, but in developing a suitable way of putting the information over at board level, and that's something we can monitor. So thank you. Any further comments? No? So
I think Ian wanted to come in.
I've
Chair.
indicated.
Again, sorry, Ian. Sorry.
No problem. Just a similar point to Mark's really, yeah. on the digital first. I was looking at that one, yes. looks really green, which is good against those actions. And to be fair, there is commentary in the overarching in the covering report around the fact that the strategic framework is going to for digital is going to be a subject of a board development. But I think it's important to note that, that we wouldn't want people to think that there isn't a huge amount of work. Yeah, if we were looking at it across the patch, it wouldn't look quite so green, I would suggest. So similar comments. Note the fact that it's work in progress, though, but I didn't want people to be under the misapprehension that we've got it all covered, because we've got a long way to go.
Well, yes, I'm sort of waiting for you to ask the question after Mark asked his, and you did. So I just hadn't spotted it in the margin. But I agree, it did look awfully green, that digital one. Or not awfully, pleasingly green. But thank you for clarifying what's going on with this, Carol, earlier. So that is fine. We've just been asked to review the progress. We're not actually being asked to approve anything here, and I think we have, and I think we've covered some very important questions. So it will be interesting to see that, you know, how things improve. We hope again improve as time passes. So thank you very much, everyone. I think it is time now for us to have a comfort break. So I don't know how long we have, perhaps 10 minutes, or yeah, everyone happy with 10 minutes? So we return about 11:45. Yes, thank you very much. Is that my camera's not working, or can you see me? You can. How odd. All right, thank you. Well, let's continue then. As long as you can hear me, that's the main thing. Right, we're moving on to the next agenda item. Carol, would you introduce this, please?
Yes, thanks very much, Chair. Really pleased that we've got one of our key transformation areas on the agenda today. Board colleagues will recall that as part of our IMTP, we have several areas that are part of our renewal and transformation work. And cancer is one of those areas. Ordinarily, Dr. Kate Wright, the medical director, would present this, but she's currently on leave. So I'm really pleased that two colleagues have joined us for this item. Claire Lines, who's the Assistant Director for Transformation and Value, is here with us, and Dr. Ruth Corbally, who is the clinical lead for our work on cancer. So I'm not planning to say very much, but to hand over to Claire and Ruth for this item. Recognising that papers have been circulated in advance, we will just give an overview, and then Chair, very happy for sort of discussion and questions. So Diolch, Claire, thank you very much for joining us, and to you, Ruth, good to see you again. So I'll hand over to you.
So thank you. So I was just going to give a very few words of introduction before handing over to Ruth. As Carol has said, it's part of our Big Four. Obviously, for people suspected of having cancer or having cancer, the pandemic is one of the areas where cancer is one of the areas where the pandemic has hit hardest. But it has also enabled us to see real opportunities in terms of how we could do things differently in Powys. Kate, as well as being the exec lead for this area, is also one of our co-chairs for value-based healthcare, where we're trying to look at how we allocate resources as a health board to get them to the parts of the pathway which will have the maximum impact in terms of improving outcomes, experience and costs. So some of our work that Ruth is going to talk about now in terms of achieving earlier stages of staging of cancer, i.e. identifying it at earlier, more treatable stages, is part of our work, bringing the work earlier in the pathways. So I'm just going to hand over to Ruth, because the slides have already been circulated. It's not Ruth's intention to go through them slide by slide, but we're just going to highlight some of the main areas, particularly in relation to our delivery plan priorities this year. So handing over to Ruth.
Thank you, Claire. So are we going to display, we could just put up the slide 4, if that's okay, Liz, because as has been said, the slides updating you about the progress of the renewal programme for cancer have already been circulated, so I'm just going to focus on the key priorities which are highlighted on the slide 4. As Claire mentioned, that sort of the pandemic has had a significant impact on cancer care across the UK, with the temporary suspension of screening services, reduced numbers of patients presenting to GPs, and the huge impact that it's had on secondary care services for both diagnosis and treatment. But it's also acted as a catalyst for the transformation of services and communication, so it has also had positive aspects for our services. So the key issues that I'm going to highlight are the FIT testing, which we've rolled out across all of Powys to help with earlier diagnosis of bowel cancer, access to the rapid diagnostic centres for those with vague but concerning symptoms which may be cancer, and also the information platform which we're developing to enable more proactive tracking of what's happening to POWIS patients beyond our border, and the clinically led harm review panel which links with this. So FIT testing is fecal immunochemical testing, and this detects blood in stool, which indicates the need for a colonoscopy to check for bowel cancer. So in addition to its use in screening, it's now been introduced for people with symptoms where the clinician or GP is concerned that there is a risk of bowel cancer, but the person doesn't fit the criteria to be referred on an urgent suspected cancer pathway. So we've established access to symptomatic FIT testing for all the practices in POWIS now, which due to our geography does mean collaborating with a number of our NHS partners. And we supported the implementation of the symptomatic FIT with a really well attended protected learning time sessions in primary care in POWIS. And up to April, just under 1,000 tests had already been completed, and this is ongoing. So now we're looking at the uptake of the service by each practice to see where more support may be valuable for practices that aren't uptaking the service as much, and also to start exploring outcomes so that we can see the impact that FIT testing is having. For rapid diagnostic centres, these are for people with symptoms who don't fit the criteria for a specific urgent suspected cancer pathway, but the GP is still concerned that there may be a diagnosis of cancer. So phase 1 was to establish the access through our commission providers for practices across POWIS. The Welsh Shrewsbury and Telford Hospital Trust's proposed service is not yet up and running due to recruitment issues. The practices in North POWIS have access to the RDC clinic in Betsy Cadwaladr University Health Board. And in South POWIS, our Straginlais practice now has access to the RDC in Swansea Bay University Health Board. The other practices in South POWIS were accessing the RDC in an Iron Bevan Health Board, though unfortunately this service has recently been paused due to workforce issues, but we're hoping it'll be up and running again in September or the autumn. However, Mid POWIS does remain a particular challenge, as there's no RDC in Herefordshire, and the service in Kidderminster is very new, it's fragile, and it's really only in the early stages of being rolled out locally. So, but finding the solution to this inequity does remain a priority to us. Phase 2 of the RDC centres for POWIS is to scope the potential for developing an RDC solution in POWIS Teaching Health Board itself. So the Wales Cancer Network is supporting us in this, and we're in the process of securing funding from the Cancer Research Wales via the Wales Cancer Network for a designated role to assist with the engagement and gathering data, and then drawing the evidence together to give us a final report to prepare, give us an idea of the potential options to determine the best model for POWIS, and whether this may be through developing our own service or through commissioned external services, or a hybrid of the two. Again, in relation to the RDC model, we have provided well-attended protected learning time sessions again to primary care across POWIS. So cancer tracking and a clinically led harm review panel has been established now as well, which includes input from the quality and safety team in the health board. As the majority of our cancer diagnoses and treatment is provided in other health boards and across in England, and we don't have the cancer specialists here in POWIS Teaching Health Board itself, we've had to develop a different approach to the Welsh Government's requirements in relation to harm reviews where there have been delays, and this has been recognised in their updated guidance now. We've established relationships with the other health bodies treating our patients, and we're receiving copies of their breach reports and harm reviews relevant to POWIS patients, so that we can understand the factors contributing to the delays and any improvements needed. Already themes contributing to breaches are emerging, including radiology capacity in particular, outpatient capacity, complex pathways where onward referral patients involving multiple MDTs is needed, and also patient factors where patients may be unable to attend for appointments or treatment. And this will help shape the planning of future services for POWIS. With the support of the Wales Cancer Network, we're also improving our access to information about patients being diagnosed and treated in other health boards through the development of a POWER business intelligence tool. So currently, this is still at the stage of development. and it's incorporating live data from our Welsh providers. And the next phase then will be to extend it to include data from our English flows as well, so that it'll cover all of the pathways that our patients are on. And it's a really exciting development, as this is going to allow us to track our patients live on their pathways, as opposed to current data, which is only available on closed pathways, so it's historical in nature. This new platform will let us see where our patients are in real time and when they're going to be breaching, as opposed to when they have breached in the past. We're also piloting the role of a cancer tracker in POWIS, and the cancer tracker role is absolutely key into this harm review process. So as set out in our IMTP, we'll also be exploring the potential to provide more diagnostics within POWIS. Radiology waiting times are a common issue causing delays in our external pathways, as I've said. So we will be exploring options for accessing CT and MRI scanning, along with radiology reporting, which is needed to go along with that. But we're also looking at new techniques, such as cytosponge and transnasal endoscopy, which are coming into Wales. We're developing a business proposal currently for an implementation pilot for the cytosponge in a community hospital setting. And this is in collaboration with the team in Betsy Cadwallader University Health Board, who are leading the implementation pilot for the cytosponge in Wales for secondary care. Exploring potential for transnasal endoscopy is also in our IMTP, and we are linked into the teams currently piloting this into the Health Board in Wales. So I'll pause there then for any questions.
Chair, if I can just thank Claire and Ruth for supporting that item. I certainly hope it gives a little bit more of a flavour of the key areas that we're pushing forward on. So as Ruth said, you know, I'm happy to take questions.
And Robert does have a question, I think. Robert.
Yep, thank you. First of all, in respect of the scoping potential for the Diagnostic Centre, I presume that this work is running in parallel with the viability work on diagnostics being carried out as part of the North POWIS project. The second question, although it's not mentioned here, it's not perhaps part of this programme directly, but it is important in improving the quality outcomes for patients with cancer. We know that there's a difference. Different parts of POWIS have different capacities to deal with palliative care and particularly, you know, night care and so on. My understanding when I spoke to somebody a few months ago was that another group was looking at this. So I was wondering if we could have confirmation that that work was continuing and whether there's a link with this work, I don't know. Thank you.
So happy to pick up the work on palliative care and end of life because it is connected to the cancer transformation work, but it hasn't been we haven't completely integrated it. I think you're absolutely right, Robert. There is an issue for us in terms of being able to support people, particularly at night in their own homes. So we are looking at that in terms of a broader approach to supporting people in their own homes, you know, district nursing, palliative care services, broader care services, to enhance the approach and the ability of families to support their loved one if their choice is to be at home. It's helpful perhaps to flag the palliative care work on the development called Cariad, which got recognition from the Chief Nursing Officer for innovative practice, where family members are supported to support their own loved ones in the care process. So definitely more work to do on that. I guess I'll see if Ruth or Claire wanted to come in on the first part of your question.
In relation to the North POWIS and CT, perhaps it's best if I pick that up. First of all, North POWIS colleagues, North POWIS programme colleagues are involved in all of the work we're doing across all the renewal programmes. In line with the IMTP, we'll be bringing forward to you slightly later in the year the work we're doing more generally around diagnostics for POWIS. we've got a work stream which is chaired jointly by a clinical lead, which is now announced as Richard Stratton, our new primary care AD, and with Andrew Goff financially, so that we can look at the opportunity that Diagnostics brings to Powys, including crucially for our North Powys programme. That has to, it's the evidence base around what will be viable, but we do need to remember the Richards report and the work Welsh Government is doing also, which has shown that the learning from the pandemic is that actually elective diagnostics, there is a significant opportunity to move those out of DGHs. In fact, they should be moved out of DGHs is the recommendation. So we've got work underway. North Powys is absolutely linked into that. We don't have firm conclusions obviously yet. We've got to bring you the strategic intent.
Okay, thank you. Are you happy with that? You're happy with that, Robert?
Yes, thank you.
So Ronnie, you're next with a question.
Thank you. I think this is a very, very important area of work. I just wanted to ask Ruth, at the beginning of your very helpful presentation, you talked about additional support that was available to GPs. I just wondered what that actually looked like and what it meant. Then in relation to TNE, which I think is a very exciting development, I just wondered quite where that sat in terms of implementation in Wales currently. And then thirdly, as I understand it, CTs are an open system. MRIs can be either open or closed. And for a percentage of patients, a closed MRI does present an issue in terms of claustrophobia. I've come across that with an English provider recently, and I just wondered where the balance sat between open and closed MRIs and what one did about patients that were claustrophobic. Thank you.
Ruth, is it best if you pick up the additional support to GPs and particularly the protected learning time, etc., and the liaison with the clusters?
Yeah, so I think that the more support, where I mentioned some more support in my presentation, was in relation to fit testing. So we want to have a look at whether all the practices are taking up the offer of the fit service, and if we identify practices where they're not utilising fit as much, the idea will be to approach the practice with offer further educational support so that they understand the criteria where it's useful, that they understand the pathway that they have for accessing the fit testing, and the implications then of the positive and negative results going forwards. So it'll be supporting the practices in that, establishing that they understand how the service works and the importance of it and the added value that it can give them. For those patients where we're worried that their symptoms may show that colorectal cancer is a possible diagnosis, but they just don't fit the criteria to access the urgent suspected colorectal pathway. I'm trying to think now, sorry, of the second question.
It was transnasal endoscopy.
Transnasal endoscopy.
Where we are with that and with Wales.
Yeah, so with the transnasal endoscopy, I'm the primary care representative for the Upper GI Cancer Site Group, which is part of the single cancer pathway across Wales. So I'm linked in with the different pilots that are going on across the different health boards for upper GI cancers. And transnasal endoscopy, with the support of the Moondance Cancer Initiative, are being piloted in South Wales across 2 of the health boards. We are interested in the concept of transnasal endoscopy because what it is it's an ultra thin endoscope which passes through the nose to visualize the upper GI tract, so down as far as sort of the stomach and the upper part of the bowel. And it's far more patient friendly than the traditional oral route, which involves a lot of gagging for the poor patient with a much wider scope involved. So what it means is that not only is it more patient friendly, but also because there's less sedation required scoping can continue all the way up to the end of lists, so that more scopes can be completed within a list than with the traditional scope. So we would have more capacity on our lists if we use transnasal endoscopy. And for the purpose in POWIS, transnasal endoscopy is just as good as the transoral route for diagnosis. It's only limited in some of the treatment potential, which we wouldn't be carrying out within POWIS anyway. But we just need to ensure that we have a nice robust endoscopy service to be able to consider implementing that for POWIS.
And if I perhaps picked up the issue of the open closed CT/MRI, so at the moment we have a prior approval process where patients are concerned about being in a closed piece of equipment, and that's what happens at the moment. We haven't actually brought that factor yet because we're not quite at that level of detail in the work we're doing around diagnostics, but I will make a note of it because it links to another dimension we are thinking through and working on. We have Joy Garfit and team involved in our cancer work because we're looking at the obviously the issue of the greatest deprivation, the greatest inequality of all are the physical health outcomes of our mental health patients, and with issues such as claustrophobia, making sure that patients have access to the services that meet their needs are absolutely part of our thinking, and it's why we've brought Joy Garfit and team into our programme.
Thank you. Can I just comment that I was surprised to see the 20%, as it were, in terms of a claustrophobia reflection. So to me, that seemed quite high, and I was just surprised by it. Thank you.
Thank you, Ronnie. Kirsty, you were next.
Thank you. Claire, can I just welcome what you've just said about health inequalities in relation to people with severe mental illness. And I'm just wondering whether a similar approach is being taken for POWIS residents with a learning disability, because similar issues occur there in terms of physical health needs of individuals with a learning disability, and some of the similar issues that we've just been talking about maybe would be a read across. So just interesting to confirm that learning disability is supporting you in your work as well to make sure that patient group is covered. I note that in the last slide it says that you are on track to improve access for POWIS residents to the rapid diagnostic centres, and I appreciate, you know, it is really difficult just to magic a centre, you know, into existence. But obviously the inequality, depending on where you live in POWIS, and GPs' access to those centres, I'm sure is a source of concern for all of us. I'm just wondering, you know, what you hope the situation will look like by the end of this year, perhaps, in relation to SAF and to mid-POWIS access to those centres.
So if I just deal with the first question first, Joy is there both with her mental health and her LD hat on, and so that agenda is shaping up. And in, you know, we're trying to do the read across also to the strategic review we're doing. So not forgotten, but we're in the process of working out what that would mean. In terms of the issues of RDCs, and you know, we're in this business that these are in different states of development, and even where they are getting up and running, they can be fragile. And as Ruth has indicated, it's particularly the sort of the access to the radiologists, which is the real problem. It's a workforce problem. So SAF and Iron Bevan, as Ruth has said, we're seeing our patients. That was working, it was underway. Our understanding is that they hope to be back up and running in sort of September, early autumn. So, you know, we're watching that space and linking with them. Ruth is in conversation, as she said, with the sort of Kidderminster colleagues, and then we've made an alternative arrangement at the moment with Betsy Cadwallader while SAF gets up and running. One of the fallback positions we have, you know, it's our geography. At the moment we're trying to get people to what will be their closest RDC, as well as Ruth is saying, looking at what might we be able to actually do in Powys that would be evidence-based and sustainable. And we're working with the Wales Cancer Network and doing this piece of research to understand that. But one option is if we get to areas that are too fragile or they can't sustain, you know, the issue is whether our patients would travel further to one of the centres that is managing to be sustainable. But we're not quite there yet. We're at the moment trying to, you know, SATH still think they will get their centre up and running as at the moment, but you know, we'll have to watch that and reach a decision point.
Thank you, Claire. I think Mark Taylor was next.
Thank you, Chair. Yeah, 2 points if I could. I seem to recall a while ago we had the paper, very complicated paper regarding the national strategy in terms of diagnostics. It may have been from ESC in terms of, and my recollection of that was effectively it was north or south, and in between couldn't be delivered because of transportation of radioactive isotopes. How are we potentially influencing that, what I presume is now starting to become an implemented strategy?
Perhaps I could pick that up, Chair. Thanks, Mark. We literally had the discussion yesterday in a meeting about the national development of a diagnostics strategy stroke plan for Wales, and where the thinking on that is at the moment, and how that aligns or doesn't with the thinking that we're having in Powys. We agreed a couple of things really. Claire mentioned the strategic intent around diagnostics. It is within the IMTP, but really important, I think, to do that work together as a board, because that is such an important development. So that the gateway to accessing care and treatment is often through that diagnostic gateway, and there's some real potential for us in rural mid Wales to provide some of that closer to home. I think there's a tension, therefore, with the national and regional thinking and approaches that we need to work through at the moment. So community diagnostic centres, I saw a paper on that recently that was sort of suggesting you could do that in 3 places in Wales, and you know, I threw my hands up and went, oh no, you know, it actually needs to be in the community, not tied to district general hospitals in that more traditional way. And we should expect to give that thinking a good run for its money in terms of the potential in rural places such as Powys. So Mark, we're in that very active discussion. We agreed that I would drop a note to my Welsh Government colleague to put that case across strongly, that diagnostics support needs to be in the rooted in community working, and the technology is developing, you know, and you know, we were just talking about transnasal endoscopy, for example. You know, it's making it easier to do things more locally for us. So yeah, important point, Mark, and we're on to it.
Thank you for that. And the second point, maybe not to unpack now, but whether it could be perhaps a subject of a report coming forward to delivery and performance, was around the data flows and the intelligence systems. I haven't quite got that clear in my mind as to how that's going to fit into, because on one hand we don't have the data, yet on the other hand we've got a system coming through that is going to give us live reports. So perhaps that could be a subject I could see coming forward to the committee for a bit more detailed look at that one. Would be appreciated. Thank you.
Yeah, thanks, Mark. Chair, if I may, I just wonder, Mark, if it's worth a conversation sort of offline, so to speak, just to follow that one up. I'd certainly welcome that, and we can then check in on what the sort of requirements are and could be.
Thank you.
Yeah, excellent. As long as we can take forward, it's great. Thank you.
Thank you, Mark, for that question. Right, so I don't know where we are now with this. Do you feel we've had a good discussion? And Carol, would you like to just round this off?
Thank you very much. Yes, really great questions and discussion on this, I think, Chair. And you know, I've seen the development of this work through the meeting that I hold, which is the Renewal Strategic Portfolio Board, and I think Ruth presented a couple of times to that meeting. So we can really see traction and progress being made. It is difficult, you know, everyone's challenged by workforce issues, and so we make progress where we can, but absolutely determined to try our very best to ensure we can pick up cancer at an earlier stage, because it is through that we will improve outcomes for people. So the team have got the bits between their teeth on that. So in terms of future reporting, Chair, clearly the IMTP reports that we had previously, but we will also make good use of the board committees to ensure that this can be tracked through. But to thank Ruth and Claire for presenting that today.
Yes, thank you, Claire and Ruth. And it's you know, it's reassuring to know that this really is one of our priorities now. So thank you.
Thank you. Bye-bye. Bye.
Bye-bye. Thank you very much. And I think we can turn now to Pete Hopgood for the finance report.
Thank you, Chair. Thank you. So included in the board pack is the finance report in the usual format. If I can just take us through and highlight on a number of key issues and then take any questions at the end. I will be focusing on our revenue position as I go through the report. So just to take you to page 2 of the finance report. So as at month 3, the Health Board is reporting an overspend of £698,000. Obviously, this is a concerning position given month 3. If action is not taken, that trend will continue for the remainder of the year. Contributing to that position, our key pressure areas are areas that I've highlighted to the board and committees on a regular basis, include complex care and CHC, variable pay, our commissioning position, mainly in relation to our English providers, and the non-delivery of savings schemes. And with that is the lack of turning our amber savings schemes into green delivered schemes. For these 4 areas, they are escalated areas now within our financial plan, and task and finish groups have been established to focus on the action needed to reduce the spend and reduce the pressure over the remaining months of the year. A key message has been given across the organisation is for all areas, all budget holders, to reduce their current run rate and take actions where needed to reduce expenditure. Obviously, without needing to say it, this is all while maintaining high standards of patient care and maintaining quality as needed. The ask has also been made that all areas identify a pipeline of opportunities to help us deliver efficiencies and to deliver that on an in-year, next year recurrent basis to help us to deliver a sustainable position. On pages 4, 6 and 7, there's some more details around our trend analysis for those key areas I mentioned, and also analysis in relation to our savings programme. If I can take you to page 9, it's just a reminder for the board is that when we developed our financial plan in line with our IMTP, there were 3 elements to the plan. There was the core financial plan, of which I've just reported the position and given the key areas for action and attention. There were then our COVID national programmes, which are funded on an actual basis. An area in relation to our other ongoing COVID response, which the assumption is they'll be funded by Welsh Government, and that arrangement was on a risk-based arrangement. So Welsh Government are asking us to reduce those costs as far as possible, but then noted as an area within our plan. And similarly, the exceptional items in relation to real living wage and the energy crisis that we're all very aware of. The reason that I highlight these areas is they're outside of our core plan. They're assumed to be funded stroke covered by Welsh Government, as was the direction when we develop an IMTP, but there is clear pressure to reduce those costs as far as possible. We also will need to have a clear exit strategy as we move into the next financial year, because there's no clarity or confirmation that they will be funded on an ongoing basis. So in part of the messaging of everything that I've gone through, this is all adding pressure on a this year basis and on a next year basis. If the cost pressures continue to grow, if we don't deliver savings as targeted, if we don't identify those exit strategies in relation to the COVID response, they will become a bigger ask for us going into the next financial year and will contribute to an underlying deficit. So before I take any questions, it's just really to sum up that the key messaging from myself to the board and to the organisation is to everyone to focus on the current run rate of expenditure and to reduce that wherever possible, and the need to reduce that to improve our financial performance, to focus on that pipeline of opportunities, and clearly the finance team providing support across an organisation in this area, looking at those areas of opportunity and of efficiency that will help us deliver on a in-year and recurrent basis. And as I've stated, those 4 key areas of complex care, variable pay, our commission services and our delivery of savings, which are now escalated areas for us, areas needing attention, areas that we're having regular reporting on terms of performance against the actions identified, and we'll report it up via committees to board as being key to helping to improve the financial position. I'll pause there and happy to pick up on any comments, questions or queries.
Ronnie Alexander.
Thank you. Pete, I think perhaps you've come to expect this question from me by now, but I just wanted to clarify where we were in relation to agency and locum staff and how much that was contributing to the variable pay dimension.
Yeah, thank you, Ronnie. So yeah, agency is a key component of our variable pay pressure. If I refer you to the trend analysis included on, just from the right, on page 6, that gives you a little breakdown of our total variable pay there. It does capture all elements of variable pay, not just agency. And in that chart, you can see our average spend for the previous 2 years and where it is for this year, which is significantly higher. It also gives a breakdown of those different areas. So as part of that variable pay escalation and the task and finish group, that is looking at how we reduce that spend on our agency staff, and clearly that's an issue financially, but it's also an issue in terms of continuity of care and other aspects. So it's a key quality focus as well. So that is a key action as part of that group.
Thank you.
Thank you. I have a question, Pete, please, if I can't see anyone else in the list. 5.6, well, it seems a very, very ambitious savings target. Can you give us some assurance that this can be achieved? Is it really achievable, please?
Okay, so as part of our forming our financial plan in relation to our IMTP, worth reminding the board that there was an expectation from Welsh Government and nationally that we return to more business as usual delivery of our savings programme. So that savings target is based on previous years where savings have not been delivered due to the pandemic in the main, and at a level that was as expected. In terms of the assurance I can give is that the number of plans and opportunities that have been identified are there that could cover that target. But in terms of the assurance at the moment, I can't give that because we haven't got a complete range of green schemes. And at the moment, those schemes are rated amber until we start to see that delivery. And I guess that level of assurance would need to come from not just myself, but from everyone in the organisation who's responsible for delivering that. So it's a difficult one for me to do individually.
Yes, I wasn't expecting you to do it. So other than that way, thank you. Were there any more questions? Okay, Carol, did you want to come in at all?
Yeah, thanks very much, Chair. I think the next meeting of the board will be at a really crucial stage of the year in relation to availability, use, deployment of financial resources. We'll be clear about where Welsh Government may be at this sort of mid-year point in September. We know that organisations right the way across NHS Wales, I'm less in the detail in NHS England, but all organisations are really struggling to get back to that pre-pandemic position. The depth of the workforce challenges are so significant for us, and the scale of the catch-up that we need to do in terms of patient care is huge, and we're operating in a context where there are system pressures on a day-to-day basis. So it's a very, very tough environment. We will need to be taking a more detailed look between now and certainly the September board in terms of additional measures and actions that we may need to take should the climate not be sort of relieved somewhat financially. And the longer term outlook is questionable, you know, in terms of what's the sort of UK government fiscal and monetary policy might be, not to get into anything too tricky, but the outlook looks quite challenging as well. So Pete's absolutely right. We have got to be developing mechanisms by which we can improve the use and deployment of the money that we've got, and that may well come down to some choices and prioritisation of where we do put those scarce resources. So the chair, the next meeting of the board is going to be critical in relation to the financial position.
Thank you very much, Karen. Thank you. So did you want to say anything else, Pete?
I don't think so, thank you, Chair. I just think it's like note those key messages I've given and the key areas of action and the need for everyone's attention and focus, because if you don't take action, that trajectory will continue for the remainder of the year.
Okay, another case for early intervention, I suppose. Okay, thank you. So that means we can turn to the corporate risk register. And James Corns.
Thank you, Chair. I mentioned earlier in the action log the activity that's still ongoing with regard to the development of the risk register, and that's further referred to within the paper. And thank you very much again to members for their participation in the board development session, which we're working through the detail of to update the register as mentioned. The main thing to draw attention to is set out with regard to the update to the current register and with regard to the financial position, which of course has just been discussed, and obviously will need to be maintained and reviewed and updated on a very regular basis as we move through. So those are the main amendment to this current version of the risk register. Happy to take any questions.
Does anybody have some questions? Right, thank you. And I'm not sure. I think Ian was first.
Yeah, please. Thanks, Viv. Just note what you said there, James, in terms of the development, and I just wanted to offer some thoughts. For me, conspicuous by its absence and the risk is the information piece that I spoke previously about the fact that we don't have an up-to-date joined up record from a patient perspective, and information is so crucial in terms of providing the highest quality of care. I'm making the joins and the links in my head to the fact that we've got that information spread over a wide variety of different technical IT systems and on paper, so that completely joined up record isn't there. We're no different to any other health board in Wales or anywhere else in the UK, but it is a significant problem, and I think it is a significant risk. I'm making the links to previous reports that we've heard about really the joined up care programme and the IMTP. We've heard about the difficulties in the cancer pathway in tracking that again, and we've also got a physical risk about our physical estate not being fit for purpose. So it is curious to me that why we haven't got a risk that our information isn't fit for purpose, and I guess does link into digital first, which is one of our 4 enablers in our health and care strategy as well. So that's the comment that I would offer around that for your consideration.
Yes. Would anyone like to respond there?
Just to say that is one of the considerations as we develop the register, and it's one of those as we work through as to whether it's a discrete risk in its own right, or it's a common theme running through a number of other items, and that's what we need to land on, so that we make sure the action and the mitigation is appropriate. But yes, absolutely noted here, and it did come out of the board development session as well.
Thank you for drawing attention to that.
Thank you.
Thank you. Are there any other comments or questions? I think, Ronnie, I'm not sure if this relates to these. I think, no, probably not. No, thank you. Well, I mean, we are where we are. I hate that expression, but I'm afraid that's what we have to say, because this is work in progress very much. And I know that the team are dealing with it and are well aware of it. So we'll see further progress, I hope. Thank you. Now we have the report of the Chief Officer of the Community Health Council, and Andrea is here to present it. You have had a chance to read it. Andrea, over to you. Andrea Blaney.
Thank you, Chair. I'm not sure if people can see me. I think there's an issue with my camera at the moment. I hope you can hear me.
Yes, we can hear you clearly.
Good, thank you. Good afternoon, everyone. Thank you for the opportunity to introduce the Community Health Council report. Much of our work continues to be done through digital means at the moment, so we're engaging with the public through our website, social media and email channels. Many of the external meetings that we attend remain to be done online, and this allows our staff and members to participate in meetings without the need for extensive travel around the county. And we've listed in the report the meetings that we've been attending and that we've had representation at. We are pleased that we've been able to get out and about a little bit to carry out some of the face-to-face engagement with the public. We attended the 2-day Small Holding and Countryside Festival in May, and we attended the Royal Welsh Show for the 4 days last week. Wednesday and Thursday were the busiest days for us last week, with people more willing to engage when it wasn't so excessively hot. CHCs across Wales have been asked by Welsh Government to gather feedback from the Welsh public about their experience during the pandemic. So our main focus at the Royal Welsh Show was to encourage people to complete our survey. It's a survey that's available in paper format and online, and is also available in a number of different languages. And the responses we get from the public will feed into the UK COVID-19 inquiry. We've taken the opportunity to join other organisations when they hold events. So, for example, we attended the PAVO Information Day in Machynlleth and the 2 recent Improving the Cancer Journey events. And we received some valuable feedback from the public who were attending those events. Dental services have been mentioned a couple of times in the meeting today, and after picking up on social media a number of concerns relating to dental services around the county, we did a quick survey to gather people's experience of obtaining an appointment or treatment with an NHS dentist. We had 200 responses in 7 days, which was just incredible. We've shared the raw data with the Health Board's primary care team, and we've had some initial discussions about the issues that were raised. We're preparing a formal report to present to the Health Board for response, and then that will be published. Our pharmacy survey received 591 responses, and we're also preparing a report on that for submission to the Health Board. In our report, you'll find links to reports which have been recently published by the Board of CHCs, and these provide information on what CHCs across Wales have heard about the impact of the COVID outbreak and how delayed care and treatment has impacted on people's lives, and also what people thought about the Test, Trace and Protect and the COVID vaccination programme. And then a separate report outlines what people told CHCs specifically in relation to the impact of waiting for diagnosis and treatment. Last week, we managed to hold our first face-to-face executive committee since the start of the pandemic, and we've decided that as we don't normally have external speakers at those meetings, we're going to try to continue to hold those in person, and we are hoping to trial hybrid meetings in the autumn, initially for our local committee meetings. We're working closely with the Health Board at the moment on some recent service change proposals that have come through from a GP practice and about the withdrawal of NHS dental services in Newtown. Our advocacy service is busy at the moment, and our advocate is providing support to Swansea Bay CHC and has taken some cases from that area. And finally, the annex to our report is Powys CHC's response to the Welsh Government's plan for transforming and modernising planned care and reducing waiting lists. And Katie, our Chief Officer, has had a meeting with Russell George, Member of the Senedd, to discuss that further. And I would just like to end by saying thank you to the Health Board staff for all the work being done during what's still a very challenging time. And as a CHC, we're really grateful for the time that the Health Board gives us so that we're able to discuss and resolve any issues as soon as possible. And I'm happy to take any questions. Thank you very much.
Yes, thank you, Andrea, for highlighting that very generously, and thank you always to the CHC for the feedback they give us, because we do learn from their reports, and this is particularly detailed this time, I think. Are there any questions? Carol.
It's comment really. So just to say thank you to Andrea and colleagues. I think you're getting really good return rates on those surveys for such a short space of time. Very, very helpful to us, and clearly underline the areas of concern. You know, we've talked about dental already on a number of occasions today. So you look forward to seeing those reports, and thanks for the work on that. Thanks, Chair.
Thank you very much.
Thank you.
Thank you. So that brings us then to the assurance report from the board's committees, and I think we can just go straight to Carol's first. They're there for information. You've all had a chance to look. We may be going to focus a little longer on Kirsty's report. Carol, does anyone have any questions about the executive committee to put to Carol?
Chair, I just needed to flag two things for endorsement of the board. It is at the end of my report, so perhaps we can go directly to that. And one is the decision taken at the executive committee to put in place an interim uplift to the funded nursing care pending the outcome of the pay award discussions. So we made that as an interim agreement, and it is in line with where the health boards are. And the second one was to endorse the decision to defer the decision making regarding changes in pathways relating to maternity and neonatal care in South Powys until the autumn, and that's because of the timing of the Independent Maternity Services Oversight panel report at Cwmtaf Morgannwg. So just those two items, if board members are content to support.
Is everyone happy to support those? They do make sense, Carol. Thank you.
Thank you.
Thank you very much. And that brings us to Tony Thomas and his Audit Risk and Assurance Committee. Tony, did you want to say anything? Or if not, does anyone have a question for you? There were no items escalated to the board, so perhaps we can take it that everyone is happy with that report and there are no questions. So that brings us to Delivery and Performance Committee. I think Mark.
Thank you, Chair. Yeah, the report is there. So just wanted to pick out a couple of things in terms of, I think as you've seen from the agenda today, there's an improvement and a trajectory to actually move our information into something which is assisting performance and outcomes rather than just reporting performance and just noting that. So I think we're moving into a more proactive phase. So thanks for the team and across the health board in terms of pulling that together. So I think that's very reassuring. I think there was some sort of positive signs from the data that we've seen in terms of us as a delivery perspective and the timescales coming down for waits in patients where we are the provider. Again, commission services are, as we've seen today, more difficult in some aspects. One aspect that I wanted to draw to the board's attention was relating to an issue that we discussed in terms of Swansea Bay University Health Board regarding out-of-hours service and basically our sort of staffing structure in a wider sense in terms of support for out-of-hours, I think has been highlighted as part of that. And I think that Swansea Bay one is obviously a contractual issue, which discussions are ongoing on. But I think as a wider workforce model, how we support out-of-hours in terms of with nursing care in particular is something that the board needs to be aware of and something to keep an eye on and take forward as we get further reports in detail. And that's all from me. Thank you.
Thank you, Mark. Ian has a question for you, I believe.
Not necessarily for Mark, but a question arising out of the minutes. I just wondered on the Digital First plan, bearing in mind that it's one of the 4 enablers to our healthcare strategy, whether there's the intention for that to come to the board.
I can answer that one. Yes.
Okay, thank you. Thank you, Pete.
Yeah.
Thanks, Pete.
That's great. All right, so thank you very much. And not surprising to have a question about digital from Ian. Very, very diligent on digital. So I think, Kirsty, you're next.
Thank you. The committee's report is as stated, but at our meeting of the 7th of July, we received a paper from the Director of Nursing and Midwifery regarding maternity services. Whilst the committee was assured around the actions taken and implemented by the Director of Nursing and Midwifery, we believed it was important that the board had the opportunity to be made aware. The paper is included in Annex 1, and Claire, I don't know whether you'd want to say a few words at this point.
Yeah, thank you very much, Kirsty. So the paper is very clear in detailing actions that have been taken recently to ensure that we have a proactive, positive response to a number of incidents that we've seen within our maternity services. The paper clearly describes the rationale for a decision for escalation within the service and an increased both level of scrutiny, but also importantly an increased level of support. So the only thing further I would want to say to board is that these measures are both proactive and positive. They are about ensuring that we maintain a high quality, safe maternity service with good patient and family experience. I'd like to assure the board that these measures are about being enabling, ensuring both increased support and scrutiny, but importantly, ensuring that we are learning and ensuring that we are taking action where required in relation to our learning. Thank you, Kirsty.
Thanks, Claire. And again, Chair, just to reiterate, the committee was assured by the robust action that Claire had put in place and was satisfied with that. So I don't have anything further to add. You're on mute, Viv. I'm not quite sure what you said.
Apologies, I had a sneezing fit. Are there any questions for Kirsty? I don't think there are. So yes, thank you for explaining that to us, and thank you, Claire. So let's move on then to the Workforce and Culture Committee and Ian.
Nothing to add to the report, Viv. Mark and I'm sure will answer any questions if there are any.
No, I think you're safe, Mark. I don't think there are any questions. Which brings us to charitable funds, and again, I don't really have. There is a list of items at the end to be brought to the attention of the board, but I think each of those is clear. So does anyone have any questions? If not, I think things are looking good for the Charitable Funds Committee and therefore for our staff and patients, which is what it's all about. So thank you. Joint committees, Carol.
Yes, thanks very much, Chair. I just want to draw attention to a couple of things. The format of these reports will change from the next meeting, so there will be more detail pulled out rather than board members needing to go through the papers and then me needing to just sort of summarise some of the areas. So for that, on the Emergency Ambulances Services Committee, as you would imagine, considerable discussion and concern about the current system pressures and the impact that is having on patients in our communities and actually on staff as well in the system. So a collective action plan has been developed and agreed. Each health board, for example, with an emergency department has committed to a tangible reduction in the numbers of hours of handover delay, frequency of handover delay, in order that ambulances are released at the emergency department and back on the streets of our communities, supporting people in need. There's a number of other areas, and I particularly flagged two areas that were agreed, and that's about exploring social care support in the control room, because the last thing people need when they need social care is to end up in the back of an ambulance for some hours and then get hospitalised as a result of that. So we're looking to see what more we can do collectively as a health and care system to support people with that need. And then the other area is a clinical advice line for care homes. The Welsh Ambulance Service is exploring that to see what additional help can be provided to care homes who are a key part of the health and care system. In relation to WISC, draw your attention to one key issue. We had a detailed discussion on recovery trajectories, and in particular, I made the point about the challenge that we have, and we've touched on this today, in the differentiation of waiting times for treatment between different parts of our population, and that is a wider issue here. The Welsh system is not back yet to pre-COVID activity, and I know that those specialist services health boards are working hard to be able to replace lost activity and potentially provide additional. So the issues of equity were discussed here, and also the issue of paediatrics, of children who have been waiting a particularly long time, and the committee agreed to have a more detailed report looking at the data that is split by specialty, provider, health board resident area, age of the patient, so children, and activity against contracted. So hopefully that provides some assurance that we are discussing these really critical matters where, again, equity and the potential impact on outcomes are critical. Just to reinforce that Ian is an independent member of that committee, so I'm sure if there are any questions, Ian would help me out.
Well, perhaps I can help out on the Mid Wales Joint Committee. Were there any questions for Carol about the other committees? Mid Wales Joint Committee for Health and Social Care is chaired by me, and Steve Moore from Hywel Dda, Chief Executive, is the lead Chief Exec. The committee is looking at perhaps streamlining the membership, slightly changing the terms of reference, and looking possibly at a different format, for example, an annual conference, which might be more accessible to more people and, you know, just make it more interesting across the whole of Mid Wales. But that won't be for me because I will be long gone, and we will need to find someone else to go in my place to that committee, either as chair, which I think is quite likely because there's no sign of anyone else volunteering from either Betsy or Hywel Dda, and or possibly just as a member if someone else does volunteer as the lead chair. So that was all there was to say about that. Happy to answer any questions. Okay, thank you. And that then brings us to the last item, substantive item really, Carol's report of the board's local partnership forum.
Yeah, thank you very much. And again, Mark may wish to come in and add. So Chair, just to say that there was a report circulated about the work of the Regional Partnership Board and the Public Service Board, which I attend both of those with some other colleagues. There's a report on the Shared Services Partnership and Joint Partnership Board. Happy to take any questions on that. But in terms of the Local Partnership Board, this is co-chaired usually between myself and Kathy Poynton. I wasn't able to be at the meeting on the 5th of July, so this was so Hayley Thomas stood in my place, and you can see the matters that were discussed. So agile working, organisational development, and there was a discussion about staff facilities. So just to say that I think this forum is an excellent mechanism by which we have really useful discussion about key strategic issues, and also, you know, issues that may not be strategic in nature but matter to staff colleagues across the organisation. So it's a very good forum. I'm very pleased to support it. I just double check with Mark whether there was anything that you wish to add, Mark.
No, I don't think so, Carl. I think in its advisory role to board, there weren't any issues for escalation. So just the minutes there in the Chair's report in Appendix A for noting.
Thank you, Mark.
Thank you. So is there any other urgent business. We have had no notification of any. Carol, have you?
No, there's just one. I have been advised that we found the answer to why the video wouldn't share the sound, and if board members wish to, we just have 2 minutes left. We could give it one more go. We're nothing if we're not persistent, Chair. So I think Liz is going to press the button if that's okay with you.
Yes, that would be lovely. Thank you. And the next meeting is the 28th of September 2022.
Hi, my name's Drew and I'm the manager at Summergill House. I'm here just to tell you a little bit about Jamie, one of our young people. So Jamie has autism and struggles massively when his routine's broken and he doesn't understand what his day's meant to look like. So throughout COVID, this had a profound impact on him. We saw a sharp increase in behaviours, and obviously it meant Jamie couldn't access the community as often. Fortunately, we managed to talk to Helen, who came to site to offer Jamie a vaccine here on site. It enabled us to put social stories in places. It enabled us to do it in a safe environment where Jamie felt comfortable, and he had his vaccine straight away with no issues. So since then, Jamie's been able to access the community with no worries and minimal restrictions, and it's been absolutely fabulous for Jamie. It's been really good.
So my name's Gareth and I'm the speech and language therapy practitioner here at Summergill. One of the tools we use to support our young people with unfamiliar or sort of ambiguous activities are social stories, which basically break up the activity into smaller portions. So before Helen came to do the vaccinations, we distributed social stories to all the young people who are having them. They really help with anxiety. They give an opportunity to see what's planned ahead and what to expect from it. And again, it always reassures them at the end to say this is okay.
To do it in.
Which arm?
Yeah, that arm. That one okay?
Okay. Yeah.
Brilliant. Thank you, Jamie. Well, you cuddle your teddy then. You cuddle your teddy then. Great idea. I'm going to pop that there. That's where the needle goes afterwards, Jamie, okay?
Okay. Good teddy cuddle. Get up after James had a needle, it says. Okay. Good. Want to cuddle your head on bed, take it there for me?
Give it kisses.
Yeah.
Big kisses, James.
You're doing
Okay.
really well.
Excellent. Well done,
Okay.
Jamie.
Ready, Jamie?
Coming up now, Jamie. Well done, Jamie. Now. Thank you, Jamie. You were fantastic. Absolutely brilliant.
Done.
Awesome. Amazing.
Jamie,
Thank you.
Jamie, feel okay? Feel okay?
Good. Good man.
Good
Good
man.
boy.
Okay. Okay. Can you go in bed and get a nice cup of tea? Go on. What do you think? Do you think?
Thank you.
Good. Right.
Hi, my name's Cassie. I'm one of the managers here at Summergill with Orbis, and just to give some feedback from the fantastic support that we've received from the Powys House Board. Today, Helen, Sian and their team have been on site and have been administering COVID boosters to some of the young people that we support. I've just been round and asked a lot of my colleagues what the feedback is from the young people themselves, and it's all been very positive. It's really helped having the facility on site, particularly because the young people that we're supporting have not had to have that transition into doctor surgeries, vaccination centres. So it's really been a very smooth process. Also, another real positive from our opinion really is that the consent that's been needed has been very thorough. So we've gained that consent from the young people themselves, if they're able to, but also obviously their families. They've been contacted. They've also been provided with numbers should anything have gone wrong, that you've requested all the correct information to be able to facilitate it, and it's all gone very smoothly, and everyone's very happy that it's received their boosters today on site. So thank you.
Oh, That was absolutely lovely. Please thank everybody involved, you know, the staff who facilitated it as well. Fabulous. I'm so glad we had the chance to see it.
Thanks very much, Chair. Goodbye now.